Hello, everyone. Thank you for joining this live webinar. I'm Hannah. I'm one of the psychiatry co-leads for Mind the Bleep. And this is the first session of the Common Psychiatric Conditions webinar series on mental state examination and risk assessment. And we have Charlemagne Tai here, who's a CT2 in psychiatry training, who will be holding the session. So I'll hand over to you. Oh, I think you're on mute.
Thank you, Hannah. Sorry about that.
That's okay.
Good evening, everyone. My name is Charlemagne. I am a psychiatry core trainee year 2. Today, we'll be talking about mental state examination and risk assessment. I will be having my camera off for this session, unfortunately, just because I'm suffering from a bit of sciatica at the minute, and it's quite painful for me to sit down. So I'm constantly needing to change my position and things. And so if you hear me sort of pause for breath or pause for a bit to collect my thoughts, it's just because I'm sort of struggling with something at the minute, and just bear with me. Thank you. Okay, we're good to start. Right. So today the plan is to go through all the components of the MSc in order, including the risk assessments. And I have sort of color-coded my slides so that the MSc components are on the blue slides, and then things that I've sort of created these other slides, these orange slides, which are more things to keep in mind when you are performing that part of the MSc, say, things to ask about, or things to elicit when you're in that part of the MSc. I've also put pathology in red text boxes. And then in the green text boxes, I've put sort of examples of what you might say when you're trying to present your MSc to examiner. Just because sometimes I find it's a little bit easier when you know sort of what you're trying to achieve, what's the end goal to this assessment, right? All right, next slide. Great. So basic points of the MSc, right? Unlike a lot of other examinations, the MSc is usually sort of opportunistic. It happens across the course of what seems to be a clinical history session, right? You're just talking to the patient, but you're also asking these questions, eliciting these signs as you elicit your history. Because it's opportunistic, even though it's opportunistic, and you might end up having to do things out of order, when you're presenting your findings to an examiner, I would suggest that you present them in order of the MSc. Just because your examiner will also be working off that same schema, and so presenting it in order just makes it a little bit easier for them to mark you. When you're presenting your MSc, I would also recommend you present negative findings as well as positive findings, just because, again, because it's an opportunistic examination, if you don't say it, they might not know if you've actually checked it. Finally, when you're presenting, I would recommend you do a description of what signs or symptoms you've elicited first before trying to put a label on it. This is just because, just in case you've put the wrong label on it, at least you have a description so the examiner knows what you've actually found. All right? Next slide, please. Great. So components of your MSc goes as follows. You've got appearance, behavior, speech, mood and affect, thoughts, perception, cognition, insight/judgment, and finally, risk assessment. And we'll go through all of them in that order. Next slide. Great. So let's start off with appearance. Appearance isn't something that's usually sort of divided per se, but I like to sort of break it down into 2 distinct components, just so that it sort of triggers you to know what you're looking for when you're seeing this patient, and then what you're commenting on later as well. So I've sort of broken it down into the person themselves, and then their clothing or the things that they brought with them. So person has to do with things like their body habitus, whether they're sweating, do they seem uncomfortable, do they have signs of self-harm? And then clothing has to do with things like, are they clean? Are they appropriately dressed for the weather? Or other objects, so things like that they could use to self-harm, for instance, right? And I've put down here in the red box some possible signs of physical health conditions. So things like vague chromocytomas or thyroid problems might result in quite a sweaty, anxious patient. They might be skinny or have a larger body habitus per se. And then For signs of mental health conditions, you could have things like self-neglect, self-harm. They could be dressed quite shabbily, or in OCD patients, they might be dressed quite smartly, or be cleaning their hands more often, things like that. Next slide, please. Great. Behavior is another one, which isn't typically divided either. But again, I like to divide it into engagement and rapport. Engagement has to do with how well the patient engages with the conversation, with the interview. So things like eye contact, body language, their activity, right? And then rapport has to do with how much of a relationship you manage to develop with that patient across the course of the interview. Again, I've put here in the red boxes things that could go wrong with both. So things like EPSEs, catatonia, depression, those could change your psychomotor activity, change how they engage with the interview. And then for rapport, things like autism, personality disorders, ADHD could change how well they are able to create that relationship with you. Next slide, please. Cool. So this is our first orange slide. It's not the most important distinction, but I just thought I would throw this in there so that we could all see what the orange slide is and what I'm trying to achieve with these orange slides, right? So our first orange slide is about the distinction between mannerisms versus stereotypes, right? Both mannerisms, and this is relevant in the context of sort of behaviors that you're looking for when you're performing an MSc. Both mannerisms and stereotypes are repetitive behaviors, but the difference is one is goal-directed and the other is not. So mannerisms are goal-directed. For instance, you might have a patient walk into the room and then open and close the door a few times, maybe 2 or 3 times before sitting down. So that's a mannerism because their action of repeatedly opening and closing the door is a goal-directed action. You can recognize that they're trying to do something, what they're doing, right? Whereas with the stereotyping, it could be things like flapping your hands, head banging, or tapping. So these are sort of things which don't have a clear goal in mind, but they're still repetitive movements, right? So these are more stereotypes. Like I say, this distinction isn't super important in exams, probably splitting hairs at sort of medical student level, but it's just to sort of get you acquainted with the system that I'm trying to use here. Great, next slide, please. Now let's talk about speech, right? Speech is broken down, unlike appearance and behavior, and I like to break it down into rate, rhythm, and tone, right? Rate is how quickly or how slowly a patient is talking, straightforward enough. Rhythm, if it's normal, you have nice, fluent speech. Otherwise, you could have things like stuttering, which could tell you that the patient is anxious, things like slurring, which could tell you about substance abuse, and then stilted speech, which could be things like brain lesions and things like that, right? Finally, you have volume or tone. This is usually loud or soft, or you could even throw in sort of more subjective qualifiers like having an angry tone, for instance. I've again put here some physical and mental health conditions which might affect their speech. I think these are things that you can sort of read through in your own time. I think that's fairly straightforward. Next slide, please. Great. Let's talk about mood and affect, right? Mood is the sort of subjective components of it, right? It's what the patient describes their mood as, what the patient feels their mood is. And it also tends to be a more long-standing measure, right? People like to compare it to the climate. So for instance, I'm having tropical climate, and that's what the weather typically is like in this part of the world. That's what the patient's mood is typically like, right? Affect is the more objective measure. So that's what you feel the patient's mood is based on their interactions with you. And people like to liken that to the current weather. So for instance, I could live in a tropical climate, but the weather today could be rainy or it could be sunny. So that's more shifting. I like to further break down affect into quality, range, and reactivity. Of this tree, I would say quality is probably the most important, just because it's how you would describe the mood, right? How you would describe the affect, the characteristic of the affect, right? Range and reactivity are good to have, and they're definitely bonus points, right? For quality, I've broken them down. I've put down here a few different qualifiers that I like to use, just because when you're in an OSCE situation, sometimes it's difficult to sort of bring these qualifiers to mind, and it's good to have a few at your fingertips at all times. I've sort of chunked them into three distinct levels: low, normal, and then high, right? So for low moods, you've got dysphoric or anxious moods. And then for normalish moods, you've got euthymic or even labile moods, so it can go up and down. And then for high, you've got elated or irritable moods. So these are sort of your manic moods, right? For range, it's how widely this person's emotions can vary, right? Do they display a full range of those emotions? If not, then you say that they have a restricted range, a restricted affect. And then if they're restricted and on the low side, you can have more specific qualifiers. So things like blunted is when they're sort of less reactive, but and then flat is for when they're completely one note thing. Finally, reactivity is how much their affect changes in response to external stimuli. So for instance, talking to a view, and it can be normal, high, or low. Lastly, you can comment on congruence. So this is what links mood and affect together in your examination. It can be congruent, where again, mood matches their affect. So they say they're happy, and when they talk to you, they seem happy as well. Or they can be incongruent, where they say they're happy, but when they speak to you, they seem to come off a little bit depressed. Next slide, please. Great. The next component of the MSE is thoughts. Thoughts is broken down into form and content. Form is about how well organized the patient's thoughts are. And I've put here a whole bunch of different thought disorders that I'm not going to go into too much detail today, just because I feel like these are sort of things that you can go through definitions online yourself, right? If anybody has any questions about specific thought disorders, I'm more than happy to talk about them at the end. I prefer to talk about content today, just because there are some distinctions with thought content that I think are important, and they don't really sort of, they could be something that you miss in your revision, right? And thought content has to do with what the patient's thoughts are about, as opposed to thought form, which is how the thoughts are organized. Next slide, please. Great. So the first distinction that we're going to come to with thought contents is delusions versus overvalued ideas. Delusions are bizarre beliefs. They're often bizarre. So things like, oh, I've seen aliens coming from space, people are controlling my mind, etc. And they're held with delusional conviction, meaning that they're fixed, and despite whatever evidence you might provide to the patient to the contrary, the patient just won't listen. Insight is also absent. The patient seldom believes that they are in the wrong. Again, despite whatever evidence you might provide. Overvalued ideas, on the other hand, are slightly different in that they tend to be less bizarre. So they might have some grounding in culture or science or whatever. They might be strongly held, but they can be altered if you give strong enough evidence, right? And there may be some degree of insight which aids with that. So for instance, someone might think that eating organic foods alone might prevent illness. So it's not accurate, but it's somewhat grounded in reality, right? Great, so that's the distinction between delusions and overvalued ideas. Then we come to obsessions versus compulsions, right? And these sort of go more hand in hand, usually in the context of obsessive compulsive disorder or OCD. Obsessions are recurrent intrusive thoughts or images or impulses that come into the patient's mind. And these are usually what we call ego dystonic. So the patient experiences them as distressing and does not want them. If the patient experiences them as non-distressing or ego syntonic, those are more likely overvalued ideas or delusions or preoccupations. With obsessions, insight is preserved because the patient recognizes that these thoughts are foreign, they are wrong to them, and they find them distressing. So insight into these obsessions are preserved. Compulsions, on the other hand, are behaviors or mental acts that are done to prevent a feared outcome. And usually this is sort of done in response to the obsession. So the patient will get these obsessive thoughts, which cause them distress, and they do these compulsions, these mental or physical acts, which relieve this tension from them. For instance, if you have an obsession that your hands are dirty all the time, you might wash your hands, and washing your hands is a compulsion. You feel compelled to do it. Again, it's ego dystonic, and again, insight is preserved. Next slide, please. Great. Let's talk about perception. Perception has to do with how you perceive the outside world, right? And typically this takes the form of hallucinations. I've decided to talk about the distinction between hallucinations, pseudo-hallucinations, and illusions, just because this distinction sort of comes up quite frequently, at least in your theory, the theory bits, right? And it's important because to clarify, in an OSCE, I wouldn't necessarily split hairs. I wouldn't specifically maybe try to pin down whether a patient is having a hallucination or pseudo-hallucination. Again, I would fall back on just describing what the patient has said to me. For instance, oh, this patient is saying that he's hearing voices in his head, or this patient is hearing voices outside his head, right? I wouldn't push that distinction. This is more just for your knowledge, and so you don't get too confused when you're trying to interpret what the patient is saying to you. So, hallucinations are basically perceptions which occur with no external stimuli. So there's no external stimuli actually happening, but the patient is perceiving something in their head. And to them, this is real and it's happening and usually it's happening in external space. So for instance, the patient might hear somebody speak to them in the room with them, but there's nobody actually in the room, right? Pseudo-hallucinations, similar to hallucinations, there's no external stimuli, but usually there's an element of preserved insight. So for instance, the patient might say, oh, I'm hearing voices in my head, as opposed to I'm hearing people talking outside, right? And the classical sort of distinction that people use to distinguish pseudo-hallucinations from hallucinations is that pseudo-hallucinations tend to occur in subjective internal space. So I hear voices in my head, right? Illusions are different from hallucinations and pseudo-hallucinations in that illusions actually do have an external stimuli tied to them, but it's a misinterpretation of an external stimuli. So for instance, there may be some noises occurring outside the room, and the patient might say, I keep thinking the noises outside are people talking. Next slide, please. Great. So I thought that we could talk about auditory hallucinations because this is the group of hallucinations that comes up most frequently, right? And it's good to have a bit of a grasp of it so you can categorize them better and also elicit them a little better during your MSc. So the biggest distinction when it comes to auditory hallucinations is whether they're elementary or if they're complex. Elementary auditory hallucinations are sort of sounds or noises, right? They are poorly formed. Whereas complex hallucinations tend to be voices, which are quite well formed, and usually they're sort of directive even. When talking about auditory hallucinations, another important thing to elicit is who is this voice? Who is that voice, right? Because sometimes this can be important for your risk assessments. If the patient is hearing their partner saying derogatory things to them, they might be more inclined to hurt their partner. Another important thing to elicit is what person these voices are in. And that's first person, second person, or third person. And that's sort of what pronouns they use. I find is the most easiest way to classify them. So first person means that the voices are speaking with an I voice, right? And this usually occurs in the form of thought echo. So the patient might think something like, I'm going to the market, or I am going to take a shower, and you hear a thought echo another voice in their head that also says, I'm going to take a shower or I'm going to the market. Second person occurs when the voices speak as in the you voice, right? So you are going to the market, or you will go to the market, or you will take a shower. And then third person usually happens when there's more than one voice in the patient's head. So these two voices talking to each other, and it happens in sort of they or he or she voice, right? So he's going to take a shower, he's going to the market. The final thing that I think is important in auditory hallucinations is determining whether they're command or non-command hallucinations. So this has this again ties into your risk assessments, where command hallucinations might tell the patient to do high-risk things to themselves, to others, etc. Next slide, please. Great. I've put in here some other hallucinations that can occur in other modalities. This is mostly for completeness, but just in case it comes up for things like when you're taking history, it would help you with your differential to know these things. I just wanted to point out that certain modalities are hallucinations in certain modalities are usually linked to certain causes, right? So visual hallucinations are usually because of problems with the brain or substance intoxication or withdrawal. So things like delirium, dementia, Parkinson's, occipital lesions, and then things like alcohol withdrawal or hallucinations. Somatic hallucinations usually have to do with substances, so things like alcohol, benzos, stimulants, etc. And then smell and taste hallucinations usually to do with brain regions, things like temporal lobe epilepsy. Next slide, please. Great. Another thing to be aware of when it comes to perception is depersonalization and derealization. Depersonalization is when you feel like you're detached from your body. So I feel like I'm watching myself from outside my body, right? Derealization is when you feel like you're detached from the external world. So I feel like I'm watching the world from afar, but I'm still inside my body. Or everything around me feels flat and artificial, but I still feel like I am real, right? And the key feature for both depersonalization and derealization is that reality testing is intact. So the patient doesn't actually think that they are detached from their body. It just feels like it to them. And that's what they'll say. It feels like this to me, right? And that's the key thing here. Next slide, please. Right. I thought, so that's thoughts and perceptions basically covered, right? I thought I would put in a little bit here about first-rank symptoms of schizophrenia, just because it's quite a nice thing to sort of try and elicit during your MSc if you think that this patient might have schizophrenia. So what are first-rank symptoms of schizophrenia? First-rank symptoms of schizophrenia are basically this list of 11 symptoms that this person called Carl Schneider came up with to try and increase the inter-rater reliability for psychosis, right? So he basically wanted to pin down a group of symptoms that frequently co-occurred with psychosis. The resulting set of 11 symptoms aren't too great, to be very frank with you. They've got low to moderate sensitivity, so 30 to 60% of schizophrenics will have this, and they've got like a moderate specificity because they're meant for psychosis in general. A lot of other conditions with psychotic features might also have them. So things like BPAD, depression, psychosis, dissociative disorders, etc., right? So why am I talking about this? I'm talking about this because if you're assessed as a psychiatrist, they will be aware of first-rank symptoms of schizophrenia, and asking about these symptoms sort of keys to them that you have this higher knowledge, that you know what you're looking for, and that you're thinking about schizophrenia. It's just an interesting way to do it, right? Let's go through these symptoms then. Delusional perception, right, is, I've actually got a slide on this. Next slide. Next slide. Thank you. So delusional perception is when there's a true perception which the patient has given a false or delusional meaning. For instance, the patient might see a red car and then think that that's a sign that the neighbor is plotting to steal his right? So that's a true perception, but it's been given a delusional meaning. Do you mind going back to my previous slide? I'm sorry, I did these. Yeah, thank you. Then let's talk about thought phenomena. These are fairly straightforward. So you've got thought insertion, withdrawal, and broadcasting. Thought insertion means the patient thinks that people are putting thoughts in their head. Withdrawal means they're pulling them out. Broadcasting means that people around them can hear or see their thoughts. Right? Auditory hallucinations are also part of the first rank symptoms, but not all auditory hallucinations, only specific types. So we've covered some of these before. Thought echo is your first person sort of hallucinations. Running commentary is when the voices in your head sort of have a narrative, just sort of narrates everything that they do throughout the day. And then third person hallucinations are when the voices are talking to each other. Great. I've got another slide for somatic passivity and made phenomena. If we could go to the next slide, and the next slide. Great. So both somatic passivity and made phenomena fall under the classification of passivity phenomena, which basically means that patient feels like there's an external force acting on them, creating these feelings, making them do things, right? Somatic passivity usually has to do with bodily sensations or movements. For instance, they're making my hands move, they're shocking my spine, things like that. Made phenomena usually has to do with emotions or the mind. So for instance, made affect means they're creating these emotions in me. Made impulse means that they're creating these urges in me, they're making me want to scream, for instance. And then made volition have to do with intent or decisions. So they made me throw my things away, for instance. All right, next slide, please. And next slide. So those are your first rank symptoms of schizophrenia. Fine, let's move back to the MFT, talking about cognition now, right? Usually, cognition can be assessed by things like the MMSE, right? But you're not, I don't think, going to be expected to perform the entire MMSE of memory during your OSCEs. What we can do is that we can look at the MMSE and see what components of the MMSE we can realistically do, right? So these are the components of the MMSE here, right? You've got orientation, attention, memory, language, and visual spatial skills. Of these 5, I think the top 4 are still doable in a natural way, in an opportunistic way, throughout the consultation. Only visual spatial is sort of difficult to put in there, right? You're not going to ask the patient to draw a clock or anything like that. Great. So orientation, things like if the patient is aware of your job role, that you're a GP trainee or whatever, say, or a F1 or F2, say. And then are they aware that you are in the GP practice, for instance, where are they aware of their current setting? Attention has to do with things like whether or not they're engaging well with the review. Memory has to do with things like are they providing a sufficiently detailed history? And finally, language. Do they have any difficulties communicating with you? I put in here a nice one-word summary that you could use, which sort of ties everything nicely together if everything is normal. So for instance, the patient was attentive and oriented with superficially intact language and memory function. Thank you. Next slide, please. Great. Now, insight. Insight can be absent, partial, or full. And the reason insight can be partial is because you could divide insights into 3 different components, right? The first is, do they recognize that they have a mental illness and attribute their problems to that mental illness? 2, are they aware of the consequences of their mental illness? And 3, are they open to treatment for this mental illness? And you can have 1 or more of these components without having all of them. And I've put in red these examples of patients having 2 but not 1 of the components. So for instance, the first example is a patient who doesn't recognize that they have a mental illness, but is aware of the consequences and is open to treatment. So I don't think I'm ill, but my work has been disrupted and medication helps. The next example is someone who recognizes they have a mental illness, doesn't know the consequences of it, doesn't fully understand the consequences of it, but is open to treatment. So I have schizophrenia and the tablets help, but people are overreacting. And the last one is someone who's aware of the consequences. Sorry, is someone who recognizes they have a mental illness, is aware that they have consequences, but doesn't want treatment. So I've lost my job because of my schizophrenia, but if you take the tablets, if I take the tablets, you will read my mind. So hopefully these examples illustrate that you can have one or more of these components without having all of them. So you can have partial insight as well. Next slide, please. Great. So I thought I'd put this slide in just because a lot of people like to comment on capacity in the mental state examination. I don't think that's a good idea, because even though there is some overlap between insight and capacity, they're not the same thing. You can have insight without capacity, and you can have capacity without insight. And the distinction is that insight has to do with understanding and appraisal of the illness. How much insight does the patient have into their illness? Whereas capacity is this physician-specific thing where you're trying to determine whether the patient can make a specific decision at a specific time. And the key word here is specific, right? So for instance, you can have insight without capacity in that I know I have dementia and I need treatment, but I can't remember what I need to do. So this patient has insight, but doesn't have capacity to make decisions about their treatment because they can't retain that information, right? Or the voices are real and I understand medication reduces them, but I rather not because of the side effects. And this is an example of when you don't have insight, right? But you do have capacity because you can understand what this medication is trying to do, and you can understand the side effects, and you can understand the possible consequences of you not taking these medications, but you can still choose not to take them if you have that understanding, right? Great. So my recommendation, comments on insights, don't do capacity unless they specifically ask for it and you specifically check for it. Thank you. Next slide. Great. Let's talk about judgment. Judgment is sort of rolled into insight, I think, and it's a global assessment of decision-making ability. Some people like to make this quite explicit. You can ask a patient, for instance, if you are alone at home and you smell smoke, what are you going to do? And that's an explicit test of judgment. But I think doing this is a bit sort of awkward, and I wouldn't do it unless you definitely think that there's something wrong with this patient's judgment. Instead, you could do it opportunistically again by sort of looking at what sort of decisions or the way they respond to your questions. So for instance, the patient's judgment may be as they have maxed out their credit cards in 3 days. Next slide, please. Okay, so the last part of your MSE is your risk assessment, right? And risk assessment is broken down into 3 distinct parts: risk to self, risk to others, and risk from others. Risk to self has to do with things like suicide, self-harm, self-neglect, or further deterioration in the mental state. It's not an exhaustive list. These are just examples, right? Risk to others has to do with verbal, physical aggression, and risk from others has to do with how vulnerable or susceptible the patient is, maybe, right? Or if someone's abusing them. Again, it's not an exhaustive list. If you've determined the patient's risks, you could also talk about how you might handle these risks, right? And of course, this is sort of specific to whatever risks come up, but I've put in here some levels of escalation that you can think about when thinking about your risks, right? And I've sort of ordered them from low to high. It starts with sort of community outpatient management. Then you can have the crisis team come in, which is sort of a short-term supportive team, which has nurses and also doctors on board, which come and visit the patient at home. They can check their mental states and also give medications if required. So that's your crisis team. And then you have crisis houses, which are these sort of halfway homes almost, where patients can go and stay for a little while if they are deteriorating in mental state, but not sick enough to be admitted into a true inpatient unit. They're sort of recovery homes where they can stay for a little while. There's there's staff around which can also help to monitor them and also help with medications and things, etc. And then you have your inpatient admission. And finally, if you're really concerned, you could think about escalating to authorities or putting in a safeguarding concern. Next slide, please. So that concludes my presentation. Does anyone have any questions?
Please pop any messages or questions in the chat and we can answer them if you have any. It doesn't look like there are any questions for now. So thank you very much, Charlemagne. That was a really great presentation, very thorough, and covered everything that I think anyone would really need to know for the mental state examination and risk assessments. Thank you very much. And if everyone could kindly scan this QR code to provide some feedback, it'd be really helpful. And you also get a certificate for your attendance through this link. So scan this to go to the website. Thanks again, Charlemagne.
No problem. Thank you.